this kind of conferences that giving a chance for the nurses to share some experiences, not only the doctors, because as you can see, most of the conferences all over the world, they are only focusing on the doctors, right? And also, before I will start, I would like to say belated Happy International Day to all the nurses. Because usually, the SSBMT we are having these conferences during May. And so, we miss that chance of saying, nurses are the backbone in every institution. Name it, even in the specialized, general, nurses is always will be the leading, who will be like 24 hours in service with the patients. In King Fahd Specialist Hospital, Damam, we started our transplant since 2010. So, I will be sharing our experiences for autologous hematopoietic stem cell transplantation in Hodgkin lymphoma. Just to sum up, this population from the mom, this is from our hospital. So from 2006 until 2019, we have like a high, or like how many percentage? From 2006 to 2007, it's like 100% already increasing. Imagine from 2006 to 2019, we have like 17,036 accumulative statistic from 2006. And then, by the way, this distribution of cases in Eastern Province, because as you can see, Saudi Arabia, and the yellow one, that is Eastern Province. It's a large mass for the Saudi Arabia. Catering with different town proper, like Al-Hassa, Daharan, Damam, Hapar al-Batin, and other provinces. Al-Hassa is leading to 27%. That's why outreach program was created from our side. And during that time as well, we are not catering only the Eastern Province. We are catering different provinces or different regions. We have patients from Al-Jub, Ha'il, Jizan, Medina, and even Riyadh. So in the cases of, in our institution in 2020, the leading cancer patient is breast cancer. Hodgkin lymphoma or the non-Hodgkin lymphoma is on the top 4. And imagine with our oncology center from 2020 to 2021, the new cancer cases increment 17%. Imagine with that. And that new cancer cases, we have like 85% is cancer, and the 15% is the non-cancer cases. Just an overview. From 2010 to 2020, we started on October 10, 2010 with 2 patients. This is a multiple myeloma patients. I am one of the apheresis nurse who collected with that patient. So now I am a clinical nurse coordinator. So I am just encouraging nurses that given an opportunity, it's always like a door. So wherever you are, just don't lose hope that, for example, that you are in a certain area and you are given an open door to be in a specialized area, grab it, learn from it, and be good on it. So from 2010 to 2020, as you can see our trend, it goes up. The blue one is for our autologous, and the red bar, is for the allogenic. So that's it. So it's increasing. Next. Autologous stem cell transplantation has a lot of indication. From our institution, we catered multiple myeloma, lymphomas, non-Hodgkin and Hodgkin lymphoma. We also have leukemia, APL, multiple sclerosis. We have one case of one ITP, and now we have a GCT. We are just awaiting for a sequential transplant for our GCT patient. The plan is to do at least three transplants for this patient. So he is due to have the second transplant by second week of June. On this manner, because I am the lymphoma coordinator of our institution, I'll be focusing on the lymphomas now. Total of non-Hodgkin lymphoma is 71, and Hodgkin lymphoma is 78. From the Hodgkin lymphoma, I'll be getting the outpatient and the inpatient. And then our total stem cell transplant done from 2010 until this moment is 311 patients. So out of that Hodgkin lymphoma, non-Hodgkin lymphoma, we have 149 patients, 94 male, and 55 female. And Hodgkin lymphoma, as I have told you a while ago, it's like 78 for the Hodgkin lymphoma and 71 for the non-Hodgkin lymphoma. Just a brief introduction. Autologous stem cell transplant, we will start with auto, means from him or from herself. So it's a process where the patient uses the stem cell to replenish the bone marrow cells which is destroyed by the chemotherapy. So primarily, the stem cell that we're going to give to the patient, it will be like a seed that will help the bone marrow to grow again. So this is a process. Sorry, we'll go back on that one. This is the process. This is the patient. Patient will be giving a mobilization. It's either chemotherapy plus GCSF or GCSF alone. During the stem cell mobilization, we will be in lymphoma, on day 12 or day 13, we will check the CD34 of the patients. If the level is more than 20, we will do collection. So the apheresis team will do the collection. After the collection, the stem cell lab will do the processing. And during the processing, before the cryopreservation, they will be using DMSO. The DMSO is a cryoprotectant in order for the cells, in order not to crystallize, that will infiltrate or will puncture the cells. So that would be for the cryopreservation, and they are giving like 10% out of the volume. For example, you have a 200 ml of volume of the cells, so it will be like 10% of it, you will have like 2 ml only. And then after that, for the reinfusion, for the lymphoma patient, we have this evaluation post the salvage chemotherapy. We will be re-evaluating the patient via the PET scan. And then after that, we will bring the patient in the lymphoma tumor board for the discussion. And I'm always hoping for my patient that during the salvage of the chemotherapy that were mobilized by the patient, that they will be like chemosensitive in order for them to go through the transplant. So this is the Hodgkin lymphoma. Hodgkin lymphoma is a type of cancer cells that affects the lymphatic system. Lymphatic system is one of the soldier inside our body who is fighting from the infection. So when your white blood cells, called the lymphocytes, goes out of control, go anywhere and like that, those lymph nodes will be enlarged. And then that would be like one of the symptoms of Hodgkin lymphoma, aside from the other B symptoms. We are using Ann Arbor staging system for Hodgkin disease and Hodgkin lymphoma. Just think, Above the diaphragm, that is stage 1 and 2. Below the diaphragm, it is stage 3 and 4. As you can see here, the Hodgkin lymphoma, this is the normal cells under the microscopic level. So the red Sternberg cells, that is the hallmark of the Hodgkin lymphoma. It consists of 1 or more or 2 or more nucleated cells. Now, question. Nurses, is autologous stem cell transplant feasible in outpatient? Yes. With all the improvements of the supportive care, and also the conditioning regimen that we are using, we will not be using it like 24 hours infusion, it is feasible. So what are the benefits of autologous stem cell transplant in outpatient? Nurses, if you're doing a transplant in outpatient, what are the main benefits for the patients? Come on. Convenience, okay. How about the others? How about when it comes to the infection? Risk of infection. So, for a shorter hospitalization, you will see that our patient will be having a minimal exposure for nosocomial infection, right? And also, cost effectiveness. If the patient is admitted for how many, like 14 to 21 days, versus the 12 days or in the outpatient that you will be seeing the patient, as a whole, you will see the differences already when it comes to the costing. So our aim for our Hodgkin lymphoma is to evaluate the feasibilities of autologous stem cell transplant. As I have said, I already laid down the questions a while ago. So what are the eligibility criteria? Psychosocial evaluation. Most of the patients going to transplants, we are having a workup. We are asking our other departments like social worker, psychologist, even dietitian, dental, patient compliance. Compliance of the patient is really a big question mark because there are patients who will say yes, and in the middle of the transplant, they will say no. Which, even if they signed already the consent, they have the right to stop or not to continue. This is another eligibility criteria that we need to be focused when it comes to the autologous outpatient. Caregiver availability. Because there are patients who would say that, okay, I have a caregiver who will be with me, but at the end of the day, they will say, no, it's my friend is not available. Or sometimes they're bringing friends. They're not even bringing their relatives. The informed consent. So of course, as a nurses, the hospital with the standard protocol, we need to secure the signed consents. So in our methods, we have 25 patients out of 78 patients, 14 male and 11 female, with a median age of 27 years old, ranging from 21 to 52 years old. Our study, the pre-transplant supportive care, the mobilization, the stem cell collection, conditioning regimen, and the graft infusion, we are doing it with allocated place. We call it C5 short stay unit. We have specific nurses who are allocated also with this. They are highly competent in handling patients. We are giving our prophylaxis medication on day -2. We are using single agent melphalan 200 milligrams per meter square. How is melphalan be given? How are we going to give melphalan? Can you tell me? How many minutes is it? Ranging for how many minutes? Melphalan, we are giving it for 15, sometimes 10 to 15 minutes. GCSF, we are giving it on day +5 until the neutrophils will be recovered. And of course, the patient will be evaluated daily in our outpatient clinic. So as I have mentioned, our patient is 25. And then with that 25 patient, we use salvage chemotherapy of a median of 3 cycles, including the conditioning regimen, ranging from 1 to 6. We have a lot of salvage chemotherapy that we are using with our Hodgkin lymphoma. We are using cisplatin base, DHAP, DICEP, ISHAP, plus or minus rituximab, plus or minus brentuximab, vedotin, plus or minus nivolumab. The conditioning regimen that we are using, as I have told you, melphalan 200 milligrams per meter square, unless the patient is having a problem with a cardiac issue. We are giving 140 milligram or milligram per meter square. And the CD34 that we are using for our patient, that we infused, there is a median of 8.03, ranging from 3.4 to 15.8 million stem cell dose. The criteria for admission, of course, if you're having a fever, maybe something is cooking, we need to inform the doctor, nausea and vomiting and diarrhea, mucositis, and toxicity of grade 3. So our result is that the median recovery of the ANC will be like 11, ranging from 9 to 14 days. Platelet with 20,000 is like 11 also, from 9 to 18 days. Admission, we have 14 patients out of 25. 7 patients would have like febrile neutropenia, and the other develop grade 3 toxicity. The median hospitalization day is 4 days out of range of 3 to 16. And the median time of admission is on day +6, ranging from day +1 and day +12. One of our patients has a contraction with a lung infection, that's why. With a day +1, we admitted the patient. And the median follow-up is 36 months, ranging from 2 to 58 months. Alhamdulillah, 24 out of 25, 96% are alive, and 92% is disease-free. There were no treatment-related deaths. On day +30 and day +100, there's no mortality in the outpatient. Conclusion, outpatient transplant now, you can agree with me. It is feasible, it is safe, and it is cost-effective. And the outpatient offers lower risk of infection, decreased waiting time for the transplant, significant cost saving, and improved patient satisfaction and quality of life. Just to sum up this nursing role of and the nursing challenges. So I will not go through with it, especially with the central line and wavering compliance of the patient. That is the most of it. This is one of my favorite slides. Clinical nurse coordinator from our institution, we are dealing our patient as a new and from the end of life. During the transplant, from the induction, mobilization, stem cell collection, conditioning regimen, infusion, and then, but you need to think, with this time, sometimes there are patients who died and patients engrafted and with a happy life like that. So our C5 short stay unit will be the one monitoring the patients, doing all the workup. I just want to acknowledge my doctors who helped me with this presentation. Dr. John, Dr. Panyotis, Dr. Abdulillah, Dr. Majid, Dr. Muhammad Zahir, and Ate Ann, Miss Ann Stanislaw, who encouraged me always to do some presentation, which is really, this is one of my phobias, so bear with me. So this is our team, this is the transplant team. So we cannot do anything alone. So the transplant has a lot of members. The medical team, nurses, clinical coordinators, C5, laboratory, and everything. So this is my references, our doctors and consultants, coordinators, our clinic, our nurses. This is the C5 first aid unit. I just want to share this one, these slides. This is our 311 patient, Hodgkin lymphoma. We have done 2 consecutive days of transplant because it's a large amount of stem cells. We have given it for over 2 days, last May 27 and 28.
Time is over, please.
Okay. So that's it. Thank you.